Chair. Ready? Good afternoon, colleagues. We are back in session, and our next item on our agenda is the Healthy Responsible Students Committee, and I'll turn to the chair of that committee, Mr. Keenan.
My name is Reginald Keenan, the chair of the HRS committee, along with, as I say, my good friend, Mr. Alan Duncan, co-chair. Today we have two matters to discuss. First of all, we'll be talking about issue session. At this time, we'll start with Dr. Hello? Hello? Can I go now? Okay, thank you. First of all, we'll talk about the issue session, using data to inform policy. And we all know that our kids have challenges now like they never had before. And definitely mental health needs it's a must priority. If we expect all our children to excel to our expectation, we must address this issue. And so the first presentation will be done by Dr. Essie, who will come forth, discuss the issues as far as the data to use to inform policy. You have the use risk behavior survey. At this time, Dr. Essie, will you proceed?
Thank you so much, Mr. Keenan. I'll be happy to. Good afternoon, Chairman Davis, Vice Chair Duncan, Superintendent Johnson, and board members. Thanks so much for having us. We're always excited to talk with you about the health of our students in North Carolina. And today we'd like to spend some time. It was pretty telling in the previous session. Mr. Jenkins said, "Let the data tell the story." And so hopefully today we'll tell you part of the story, and hopefully some recommendations that we can think about taking to address some of these health issues that you'll see in the data today. As always, we ground our work in the whole school, whole community, whole child framework that puts that student right in the center. And I think very importantly, as we're thinking about what we've heard already today, the importance of the community in which that child lives and how important they are to the overall well-being of the student. I'd be remiss if I didn't say that there's a whole team of folks who helped to get the work going today. With me today, I have Mr. Les Spell. He's our data and policy consultant. And while I'll be talking about the data, he may be chiming in from time to time because he's the brains behind the data. So together we'll see if we can't share this data and be happy to answer any questions moving forward. So there are three types of data that we collect within our section. One of those is the Healthy Active Children Progress Report data. We're collecting that right this minute from all 116 LEAs, and we get data on how they're implementing the Healthy Active Children policy. We also collect school health profiles data, which looks at policies and programs that are going on in our districts. And then what we'll be talking about today is the Youth Risk Behavior Survey data. Next slide. So a little about the Youth Risk Behavior Survey. It is a North Carolina survey, also a national survey, but we conduct the North Carolina survey at the middle and high school levels. It's administered in odd numbered years, and it's been administered in North Carolina since 1993. So we have a wealth of trend data on what has been happening with our students since 1993. All schools and classes that participate are randomly selected, and participation is voluntary, both at the school level, at the classroom level, and at the individual level. Parental consent is required to participate in the survey, and it's designed to be completed in one class period. And then finally, and most importantly, the answers are completely anonymous, so there's no way we can tell what student answered what question. A little bit about the survey and what types of questions it asks. It looks at behaviors that contribute to the leading causes of mortality and morbidity in students or in individuals. And those are unintentional injuries and violence, sexual behaviors, alcohol and other drug use, tobacco use, unhealthy dietary behaviors, inadequate physical activity. We also, at the high school level, look at obesity, and then some other priority health issues, and some of which I'll talk about later on. I think it's important to note that this survey does ask students. It gives them a voice to talk about their health behaviors and things that they see as important to their well-being. So just an overview of who took the Youth Risk Behavior Survey. The state sample was 3,056 high school students, and this is the high school survey. I'm not presenting middle school data today, but we do have middle school data as well. We had 3,056 high school students. You can look there on the side at the percentages of students based on race, Asian, Black, Hispanic, white, multiple races, and then all other races. So the pie chart gives you a breakdown of where most of those students, of the demographics of those students. If you look at the next slide, I think it's pretty telling that the pie chart on the left are the demographic breakdowns of North Carolina public school students. The one on the right are the students who took the Youth Risk Behavior Survey. So yes, Mr. Ford, they mirror almost perfectly. So we feel that we're getting a good representation of our students. Also, we oversampled some districts. And what I mean by that is that we took large enough samples, enough students took the survey that we could get county level data for these districts. The districts that are in green are our whole school, whole community, whole child pilot districts. And if you remember, our folks have been working with us to really implement the whole school, whole community, whole child framework. And they're still with us, even in spite of the fact that they haven't had any real financial support to do that, but they've really been involved. We also had some districts that requested their own data, and so we oversampled those as well, and you can see those in blue. In addition to the fact that our districts use that data to inform their work, they can see what's going on with their students and use that to then make decisions. Many of our partners also use the Youth Risk Behavior Survey data. The Child Fatality Task Force in particular has used quite a bit of the data that we'll be sharing today. The Department of Health and Human Services. I think it's also noteworthy that one of the measures in Healthy North Carolina 2030 is also the Youth Risk Behavior Survey question, or two of those actually. So many partners use the data. And these are just a few. We have many more. So let's then talk about students by the numbers. Here's what we know about our high school students. So we'll start first with vaping and cigarettes. The question we ask students is, are you currently smoking cigarettes? If you look at the blue line, the percentage of students who are currently smoking cigarettes in North Carolina has decreased from 2015 from 13% to 8%. But the green line are those who currently used electronic vaping products. And that has gone, it went down a little bit in 2017, but a significant increase in 2019. 36% of those who are vaping, that is a higher percentage than our smoking number has ever been, to put vaping in context for you. And this picture, these are vaping products, just a sample of vaping products that the Division of Public Health has used to do some testing on the contents, but these have been confiscated from North Carolina students. So it just gives you an idea of all the different looks that a vaping product might have. We also ask students about their physical activity levels. The percentage of high school students who are physically active at least 60 minutes per day on 5 or more days, previous days. And sadly, since 2011, this has gradually gone down, and pretty significantly since 2011. So fewer high school students are being physically active on 5 or more days. And I'll come back to that a little bit later. We also ask students about eating breakfast. The percentage of high school students who did not eat breakfast has gone up. It stayed about the same since 2011, but in 2019 we saw a 4% increase in the percentage of students who were not eating breakfast during the 7 days before the survey. So then we asked them, did you eat, on the next slide, the percentage of high school students, if you ate breakfast all 7 days, and that has gone down. We have fewer students eating breakfast on all 7 days, especially since 2017, a decrease there to 2019. So we started thinking about that, and so we asked our colleagues in school nutrition, Dr. Harvey and her team, is this what they're seeing as well? Because we wondered with the actual numbers. And the total number of breakfast served has gone down since the 2016-17 school year, by 4 million breakfasts sold, or served. So that's a 4 million breakfast decrease. That's in spite of the fact, if you look at the next slide, that total breakfast programs have increased since the 2016-17 school year. And then there are different types of breakfast programs, and they've all increased, I think, except maybe breakfast on the bus might have decreased, and one other one decreased slightly, breakfast break. But the remaining types of breakfast programs have gone up. So we continue to offer our students breakfast, but then our numbers are looking like not as many students are eating breakfast. So one of the things we have to think about is not just what do we offer them, which is incredibly important, and we want to make sure that all of our students continue to get access to breakfast. But if we look at the next slide, we need to think about how do we teach students about the importance of breakfast. And that's a role that our classroom teachers and our healthful living teachers can play. If you look at the North Carolina Essential Standards for Healthful Living, for health education, these are just two of our clarifying objectives in kindergarten and then in 3rd grade about the importance of eating breakfast and how to make healthy choices. We can't just provide the services and then not provide the education that goes along with it. So I think the classroom teacher has a role to play in this as well. Another area that we look at with the survey is school safety. This was when we could be in the education building, and these are our colleagues last year for National Bullying Prevention Month, which is right now in October. And we'll share more of that, another picture about that a little bit later. So we looked at school safety data. And this particular question has really bothered us for a while now. The percentage of high school students who did not go to school because they felt unsafe at school or on their way to school or from school. In 2017, we had, for at least one day during the last 30 days, that's how that question was asked. In 2017, we had a really significant increase in students who didn't feel safe at school. And we weren't concerned about that and thought, well, let's see what happens in 2019, see if that levels off. And we were surprised to learn that it did not level off and that more students felt unsafe in 2019 than in 2017. So if you look at the next slide, it talks about the demographics for those students. And while our Hispanic students felt the most unsafe of all of our students, the trajectory for each demographic went up during that time. So it's still bothering us. So on the next slide, we decided to compare that to national data, and then the blue lines represent the National Youth Risk Behavior Survey data. And while they've seen some increases in that data for students as well, our North Carolina data is significantly higher. So I think this is one of the areas that we're constantly thinking about, talking with our colleagues in the Center for Safer Schools, working on different strategies to think how might we address this lack of safety for our students, or lack of feeling of safety, I should say. Also looking at the mental health needs of our students. We asked students, this percentage of high school students who strongly agree or agree that they feel good about themselves. And in 2011, that was 80% of our students. That has continually gone down. In 2019, only 60.4% of our students say they feel strongly that they agree that they feel good about themselves, excuse me. We also asked them the percentage of high school students who agree or strongly agree that they feel alone in their life. So students are feeling less good about themselves, and they're feeling more alone in their life, and that has been a significant increase since 2017 as well. And I do want to add that this data came in pre-COVID, just for your reference. The percentage of high school students who felt sad or hopeless, and the way we ask that is that we ask them if for almost every day for greater than 2 weeks in a row, so much so that they stop doing their normal activities. And so what we're getting at is a clinical definition of depression, and that number has increased since 2017 from 29.4% to 36.3%. So another significant increase. So this slide is one that I told you I'd come back to the physical activity data. Percentage of high school students who were physically active and those who felt sad or hopeless, or those that were depressed. So if you notice that as physical activity decreased, students who felt so sad or hopeless that they stopped doing normal activities increased. I'm not indicating the cause and effect there, but rather a correlation between those two. Much of the literature has suggested that exercise is one way to help address depression. Clearly, it's not going to take the place of the need for mental health services, so I'm not suggesting that. But it does talk to us a bit about the need to increase physical activity among our high school students. That certainly couldn't hurt in helping them. And again, just a reminder that our middle school students who are required to get 30 minutes physical activity at school daily, didn't see numbers drop that significantly. Next, we take a moment to look at our suicide behaviors among our high school students in North Carolina. If you look at the legend, blue is seriously considered attempting suicide in the past 12 months. Yellow made a plan. Green attempted suicide. And then our purple is made a suicide attempt that resulted in needing treatment by a medical professional. And if you look at those numbers, they have increased steadily since 2013. But if you look at 2013 and 2015, you'll notice that there's no green line there. In 2013 and 2015, we did not ask students if they attempted suicide. We only asked them if they made a suicide attempt that resulted in needing medical attention. And in 2015, we were so shocked by a number that was 9%, which would have been an incredibly high number of students attempting suicide and needing medical treatment. We were so shocked by that number that we called the Centers for Disease Control, who helps us with our data, and asked them to rerun the data to see what was happening there. Didn't seem like there was any problem with the data, so the next year we added the question, have you made attempted suicide, back in. Once we did that, we saw those numbers of needing medical treatment move back toward national averages. And not that that's wonderful that it's 3%, but that told us that we didn't have quite that high of a percentage of students that needed medical attention. It also told us, though, that we had a lot of students who wanted to tell the story. We talk about student voice. They wanted to tell us that they were dealing with suicide ideation, and adding this question back allows them to do that without actually having to say they were seeking medical treatment. We also looked at this data specifically among our gay, lesbian, and bisexual students. In every category, they were at least 2.5 times higher than their heterosexual counterparts. We also, in the past year, and I'm going to ask Les to talk a little bit about this because he's been doing some research around this question, what we saw among our Black students.
So in the summer of 2019, the University of Toledo released a national study of Black adolescents, and they saw that there was increased attempts in suicide, completed suicides, and other areas around suicide, such as considering suicide in Black adolescents. And when I saw that data, the national data, the question came to mind, well, does this hold true for our students in North Carolina? And the data that we have available is the YRBS data. So when we looked at the Youth Risk Behavior Survey for our high school students, our Black students were the only demographic that increased every year in seriously considering suicide from 2009 up to 2017. So much so that by the time 2017 data came around, our Black high school students percentage for seriously considering suicide was higher than what is traditionally considered more of a white student issue. The Black students number was higher than our white students. Then when we got our 2019 data for YRBS came in, we saw a significant increase in our white high school students going from 15.4 up to 20%, while our Black high school students still remain significantly higher than what they had been in the past at roughly 16%.
So again, very significant increase. Thank you, Les. The other question that we often get about this data is how does that relate? Is this true? Are students telling us the truth? And Les, I'll let you just go ahead and finish this slide as well, if you will.
Okay. So we got data from what folks would consider hard data. We went to the State Center for Health Statistics and asked for, what were their numbers for self-harm and self-inflicted injury for the ages of 10 to 18. And so the data we get back shows that there were increased numbers for emergency department visits in hospitals in North Carolina between 2016 to 2019, which is similar to the data we've been showing you from the 2017 YRBS data to the 2019 data. And we see that the emergency department visits for that age group has increased every year and is pretty much in line with the increases we're seeing in regards to mental health issues and suicide ideation from our high school students. The hospitalization numbers, you don't see the same increases there because there's other factors that go into hospitalization, whether a patient had insurance or other reasons why you wouldn't see the same number of increases on the green bar.
So we also asked students, the percentage of high school students who agree that their teachers really care about them. And if you'll remember, previously this was a state board measure. Sadly, it's gone down since 2011. That has gradually gone down. And I'm not sure that's necessarily I don't believe that's a reflection of the teachers not caring about their students, but rather perceptions of students. And, those of you who have ever taught, that if you have a bad day and it shows on your face, and students perceive that often as a reflection of them when really it's your issue. So, because we know, obviously, if you look at the next slide, that we have tons of teachers who really care about their students, including Ms. Clemens, your principal of the year. This is part of our bullying prevention month work, and we appreciate her participating in that. So looking at the state board goals then and how this work fits into your plan. So on November 3rd, 2016, the State Board passed a resolution establishing the whole school, whole community, whole child framework as a framework for the state and for the State Board of Education into centering your work this way. Last month, you passed a resolution to support equity and excellence in North Carolina public education. And we know that you can't have one of those resolutions without the other one. A child can't be healthy without equitable access to services. And in order to have that equity, we have to look at the whole child. And so what we did is we took those resolutions and we put all those words together into a Wordle. And if you're familiar with Wordles, you know that the words that come out most often are the largest. And so we put both resolutions together and we saw those kinds of things: the whole child, the student and student supports, health, barriers, local. So you can see equity. You can see all those words that kept coming up more and more often indicate that this is work that has to be done in conjunction. It also is important work if we're going to meet the guidelines of the West Ed report, especially those related to health and equity issues for students. Those two resolutions and the work we're doing needs to continue to work together. So then measures that we added. You have a second handout as part of your board materials. We added some questions to the Youth Risk Behavior Survey for the 2021 administration that we think might help you as a board get more information from our students, a way to hear more of our student voice. We asked a few more questions about how students interacted with their school, what kind of voice they had at school, what role they play in their consequences, in their behavior and consequences, what role their race and ethnicity has played into how people treat them. So we added some more questions, and you have that handout, and feel free to look at those, but we hope they'll help you. So going forward, what does this mean for our students? One of the things that we've heard a lot about over the last few years are adverse childhood experiences, and much of the research and literature now talking about the fact that COVID-19 will be an ACE. It will be something that we have to think about because it so strongly impacts students and families. And in order to address some of that, we're going to have good mental health supports. And when I talk about mental health supports, I want to mention that from the perspective of a team support. We have a lot of times when folks say we need more support for mental health, sometimes they're talking about mental health services, therapy or counseling, those kinds of things. But we also, in addition to that, we do need that. We also need the service providers in the schools that can help work on prevention and also help be the access to those services for our students. So I just wanted to mention those 4 areas and their ratios briefly. The first is school counseling. The pictured here is Cynthia Floyd. She's our school counseling consultant here at DPI. School counselors do, and they all do different things. And I think that's why I hope you'll look at these 4 slides to recognize that. School counselors do academic, career, and social emotional skill development. They do small group and individual counseling, crisis intervention. The recommended ratio for school counselors is 1 to 250. In North Carolina, that's the ratio is approximately 1 to 353. Then there's school social workers. This is Pacovia Lovett. She's our school social work consultant at DPI. School social workers do a separate kind of work. That, in addition to crisis management, they connect families with resources and the community. They alleviate some of the family stress, including barriers to school attendance. If you know a school social worker, you know they're trying to find out where the students are and make sure they're in school. Talk a lot about attendance. They provide mental health services. Their recommended ratio is 1 to 250. The North Carolina ratio is approximately 1 to 1289 currently. School psychologists are also important. They have a separate set. Some of their duties crossover, but they screen for academic behavior and emotional barriers to learning. They look at development and monitoring of individual student behavior intervention plans. They do psychological assessments. If you look at the recommended ratio for school psychologists, it's 1 to 500 students. The North Carolina ratio is approximately 1 to 1789. This is Lynn McCord. She's our school psychology consultant at DPI. Again, we're not meeting our ratios at this point. And then finally, in that group of 4 that do a lot of that teamwork is our school nurse consultant. That's Ann Nichols. She's a state school nurse consultant. They manage clinical health services, do screening assessment for health issues and for mental health issues. They do a lot of work with students who have complex health needs. And their current ratios, recommended ratios, are 1 to 750, or actually 1 per school. That's kind of been adjusted over time. The North Carolina ratio is 1 to 1,007. So when we advocate for funding for those 4 positions, we can't just look at the ratio of any one position. We have to think about them as a collective and advocate to meet all the ratios. And then our districts, our LEAs and schools and charters can determine at what level they need each of those services. But we should advocate for a collective group of those because we do need that team. And also we can't forget that when we're advocating, we also have to continue to teach the standards. The first thing I thought when COVID hit was, well, our physical education teachers talk about personal space quite often, and sometimes they use hula hoops to explain to a kindergartner what personal space is. You can't say 6 feet if you don't try to start explaining what that space around you looks like. And also, there's not an elementary teacher around that would be teaching hand washing, especially on October 15th, which is hand washing day. Additionally, I think, and this is a shout out to the Standards Curriculum and Instruction Division that has been doing incredible work on social emotional learning integration. When we talk about social emotional learning, we're looking at those 5 competencies of the CASEL model there: self-awareness, self-management, decision-making, relationship skills, and social awareness, and really trying to integrate how do students do those things into every class that we teach. And starting Thursday, there will be a series of webinars that look at the different content areas. How do I integrate social emotional learning into my English language arts class or into my math class? They're always in the health objectives and the school guidance standards, but including that integration all the time. And we've worked, there's a large group of a large team, agency-wide, that's working on SEL integration. I think the work that Beth Rice and the rest of the team has done to pull together this work is pretty amazing, and I think it will. I think Matt will probably talk a little bit more about that in his presentation. So be it resolved in action. Several of the things that could be done to help address some of the data that you've seen today. One is to implement a statewide oversampling of districts for the Youth Risk Behavior Survey. If all districts got the data that the ones you saw on that map got, we would really have a good picture of what's going on, and we could tailor our interventions to what's happening in each individual district. Support the hiring of mental health professional teams to provide those coordinated services for students. Again, it's a team approach, and thinking about getting all of those so that they can address the needs as teams. Hire a chief health officer, a state level whole school, whole community, whole child consultant, and regional consultants to help focus this work both internally at DPI and externally in the field, providing the support that school districts that across the state need. Increasing the graduation requirement for healthful living. Quite often, legislation is passed that adds something else that we need to teach in the health classroom. And the challenge there is that to graduate from high school, students need 1 semester of healthful living. That's half health and half physical education. So working to increase that. And then finally, as we looked at that data on physical activity, possibly expanding that Healthy Active Children policy to high schools to try to encourage more physical activity among our high schools. So I know that's a big list and a big ask, but I think there are things that we can certainly consider and think about, and hope you as a board will do that. because now more than ever, we need healthy children that are able to learn better. And with that, I'll stop and see if there are questions.
Any questions from the members?
Mr. Chairman,
Yes.
Wendell Hall.
Go ahead, Mr. Hall.
Thank you, sir. I have a question. Going back to the slide that we used concerning kids not feeling safe going to school, also at school. Of course, that was eye-opening to me because I've always believed that children felt safer at school than anywhere else. My question is, could you determine as to exactly where that unsafe feeling comes from? Was it physical assault? Was it bullying? Any data on why? The particular incidents that they felt unsafe?
That's a great question. One of the drawbacks for that particular question is it asks students if they feel unsafe at school, on the way to school, or coming home from school. So we don't know which one of those they're thinking about when they answer the question. And that's the only data about that we get with this particular survey. So we don't have more in-depth data on that.
Okay. And of course, the issue with SEL, which I totally agree. I totally agree with that whole child concept and dealing with the social emotional learning. If we have the resources, do we have the personnel to put in place to take care of these needs of the ACEs that we know is going to come?
Are you asking, does the school district have that personnel?
Do we have the personnel out there that we could secure services for should we increase funding for SEL integration? Are you with me?
Yeah, you mean like if we refer students, do we have resources for them?
Correct.
Yeah. I don't know the data on that. I'm not sure. I would guess that we would probably need more services, but I would like to think that if we're able to get those referrals out there and then we can continue. I think we're always working to get more direct service provision available for our students.
And those ratios that you were sharing with us, like 1 to 1,700, and the counselor is probably 1 to 750. Is what the
counselors are actually 1 to 353, I think. Yeah.
And right now for us it's what, 1 to.
Well, North Carolina is 1 to 353. The ratio is 1 to 250.
Right. Okay, I just the health issue. Oh, the other thing is, what about the children has gone from tobacco use to vapors? Have they given any? Have you have any data to say the reasons why they've gone from pure tobacco to the vapor?
I would speculate that a lot of that has to do with how much easier it is to obtain vaping products than it is to obtain tobacco. Not to mention, you could. There are so many. If you saw that slide with all those different products, students can bring vaping products into the classroom and they're not as noticeable as a cigarette might be.
Okay. Thank you. I appreciate it.
Sure.
Mr. Chair, this is Mr. Ford. Can I ask a question briefly?
Please do.
Thank you. This is, wonderfully useful data. And, at the same time, as I'm saying, it's wonderful, it's also heartbreaking. I have to confess, my heart is, beating fast just as you went through each slide. I have a million questions. I know can't answer all of them. And so, my question does dovetail off of Mr. Hall's, and that is, which you've already partially answered. The students report feeling unsafe. When we broke that out, racially and ethnically, since 2013, there's been an increase in Hispanic or Latinx students. And I know you already said that the data don't necessarily tell you, why that is. I could certainly speculate on what might be driving, those feelings of unsafety for that community going to, at school or coming from. But is there any way for us to, sort of test the hypothesis as to what might be driving that for that particular racial and ethnic demographic?
We could probably, and Les is probably going to cringe when I say this, but we could consider, especially if we considered a statewide implementation of youth risk behavior survey, working with the CDC to see if we could get an additional question that would try to get at that.
Yeah, I just, as we think about eliminating gaps, and, I'm of course interested in the increase in suicide overall, but, speaking specifically to the Black high school students, that was astounding as well. But, the young man in our last panel talked about different students needing different things. Mm-hmm. And as distilling as best we can what those different things are with precision, I think can just aid us in helping to hold fidelity to that. So thank you.
So thank you. And I would like to just follow up on that. One of the things that happens when we oversample our districts and they get their own data, they're able to sit down and say, what else do we need to ask, and look more specifically at what's happening with them. And I'll give you an example. One of our districts got that number that was incredibly high in 2017, and immediately the superintendent pulled together the SROs from their schools, their counselors, their local sheriff's department, their someone from their school bus transportation, and they sat down together and they said, what is it that's going on? And they really worked to try to come up with some solutions and make some changes that would support the students. So sometimes when we get the number, then each individual community has to dig a little deeper to see what strategies will work for them.
Anyone else? Comment, questions?
Yes, Mr. Keenan, I do have a couple of questions, or a question and a comment. This is
Go
Ms.
ahead, Ms. Kent.
I just want to add to Mr. Ford's comment about the heartbreaking nature of some of these numbers. And I just have to say that I can't help but think about what these numbers would look like if we could sample those same kids right now. And it just adds urgency to our need to get these kids back in school. They've been further isolated and away from the support systems for many, many months. And I just fear the mental health problems that are going on out there. That being said, Dr. Essig, is the barrier to statewide, to giving this survey statewide, is it financial?
Partially, yes. If we chose to do a statewide implementation, it would take. So far, the Centers for Disease Control have been very supportive partners. We've had a long history with them, and they've analyzed the data for us as part of our other data sets. But we would, as we're hoping to go online with our administration next year to make it a little more, a little easier for our students to do quickly, we would have to pay a little more to get that work done. It would cost more, yes. Also, I wouldn't say we've never really asked to go statewide before. So that would be a first request, but we could make it happen with the finances would be important, but it wouldn't be astronomical to go statewide.
I think that's a very important ask to make, and we should definitely think seriously about that. Thank you.
Thank you.
Mr. Chair, can I just briefly state for the record that I agree with Ms. Kamitz, and I think that we should explore the recommendations offered by Ms. Essig. That's all. Thank you.
Well said.
Mr. Chair, Matt Bristow-Smith.
Yes, go ahead.
Dr. Essig, I just want to thank you for, once again, a compelling presentation. I always learn so much from your presentations to the board. I want to ask, would you mind scrolling back in your presentation to the statewide map where you indicated which districts were in fact participating in the Youth Risk Behavior Survey?
There.
Yeah, so So visually, I think this gives us a really interesting representation of where the pilot schools were, and then also requested districts like Edgecombe, where I work, asking for this data so that we can understand systems and processes that help to marginalize students and that just create barriers for kids to be successful at school. One of the things I'm really mindful of, and you guys have heard me speak to this before, is that there's a large band of Tier 1 counties in eastern North Carolina, and I see there, south of Edgecombe, south and east of Edgecombe, we don't really have many, if any, districts that have participated in the Youth Risk Behavior Survey. And so what I'm wondering at, and where I'm trying to go with this is, it seems to me that it would be incredibly powerful data for us to have, first off, statewide implementation of the Youth Risk Behavior Survey, as Jill and James just called for. But secondly, for us to be able to break this out by tier counties, and so that we could see the impact of affluence upon these indicators that you guys measure in the Youth Risk Behavior Survey. So I think that compels us, if we're truly trying to eliminate opportunity gaps, to get this data from just a variety of different data points, including Tier 1 counties in particular. So I just wanted to call that out. Secondly, I want to ask you a question, and the policy question, two in fact. One, could you see a natural integration between the North Carolina Education Corps that we've been learning about and some of the services that, for example, a school nurse or a school social worker might offer to a school? I'm wondering if there might be a budding integration of those two programs. And then two, could you see a system where school nurses were allotted by school the same way that school principals and teachers are allotted, so that rather than depending upon necessarily funding sources, it's just an allotment that schools get? And so I wanted to ask you to comment on those two policy questions.
So first, I wanted to clarify your sampling discussion earlier, just to make sure everybody understands yes, if we oversampled all the districts, we would be able to break out Tier 1 counties and we would get some very specific data about them. But I also want to note that they are included in the statewide sample so that we have a representation from across the state. So when the sample's pulled statewide, we do get a representation for the statewide data that I just presented to you. But if we had individual county level data like that, we could then look at how those trends look in regions and areas across the state. So I just wanted to clarify that to make sure everyone knew that it is a representative sample of the entire state for the statewide data. But we could learn so much more if we had individual county level data. I'll also say that I think it would be great if we could allot school nurses or school counselors or any of those folks. I think obviously the funding seems to be the bigger challenge with that. But if that was there and they had the funding and to allot those nurses, I think that would be incredibly important. Our nurses today are doing work. I think sometimes people remember the school nurse and think of, well, I needed a Band-Aid, so I went to see the school nurse. And our nurses, one of the current funding sources that we have from the CDC looks at the management of chronic conditions, and we have actually funded a position at the Division of Public Health, Division of Public Health, to help us with case management across the state, so that we're looking at students and we're managing their health cases throughout the year. So a student, if we know that a student has asthma, for example, we have a case management plan for that student, so that we ensure that they make it through this year and aren't in the hospital for asthma, because they're being managed throughout the year. And to do that, we need a greater workforce of nurses. So I like the idea. You find the funding, and we could find the funding. I think it would be a great way to allot those, not just nurses, but the other positions as well.
Mr. Keenan? Mr. Keenan, can I ask a question? Well, actually, you have 3 observations and/or questions.
Who is this?
This is Alan Duncan.
Okay, sorry, Alan.
First question, with respect to our the idea of a chief health officer, is there
any thought to perhaps partner with DHHS? We've learned a lot this past year about how important the relationship is between DPI and DHHS with respect to the pandemic, which is an unfortunate way to find out just how closely tied we are, but we certainly have learned that during the year. Is there a way we can think about getting with our colleagues at DHHS and looking at a plan to do this, because it certainly impacts the work, obviously, of DPI as we're discussing, but equally as obviously the work of DHHS. So I think the thought there is a good one. Is there a way that we can entertain that as a joint thought for the welfare of our children? That's first question / thought. Second one has to do with the ratios that we have here. The best I could tell, the best ratio we had was about 1.5 to 1, and that was school counselors. I think the worst ratio was for social workers, which looked like it's something like over 5 to 1 in terms of being, we should have 5 times more than 5 times more than we actually have. For those who have spent a lot of time in schools, you know social workers play a very prominent role in helping a lot of students. They also have played a prominent role in helping our dropout rate decrease over the course of the last period of time, and many of them genuinely qualify for sainthood, as do the other workers in these categories, our nurses and our school psychologists and our mental health workers. We are so far behind in all of these categories. I think we rightly and often say we care most about those we have the least, which is our children. And we want to say and believe that's who we are. But these numbers would suggest it's not who we are. And as a state, it is not what we are doing. It's not what we may have words that are good, but our actions are not following through on the words to truly look out for the welfare of our children. It would require a significant expenditure to help our children, but we have realized during this pandemic, as Ms. Kamnitz has very thoughtfully commented already, just how severe these issues are. They're likely to get worse, and there is a shortage of ability to address all of the needs. And I'm fine with revisiting ratios, revisiting whether it can be done through schools. But I don't think there's anyone who, with straight face, would acknowledge that we don't need more work, need a lot more people helping us in this area. We need to make this a state priority. If our children are a priority, and they absolutely should be, if they're our priority, then we need to better serve that priority. Their health and well-being is way too important for these kinds of ratios to exist, and for us to have to look at these kinds of ratios on an ongoing basis with no real improvement in sight. So I appeal to everyone's best senses in looking out for the welfare of our children to address how is it that we do something different and something better for our kids. The last item goes to, there's been several comments about funding playing a role here, and so this is not really a comment, this is a question. Title V has traditionally played an important role in some of our funding. What's the status of our Title V funding at this point?
We are currently finishing up the last of our Title V funding, and are not accepting Title V funding for the next year.
What is the reason that we're not accepting Title V funding, given that it's an important component to our overall work here? And did the board make a decision not to do that?
No, that was a leadership decision.
About how much funding is that approximately?
Approximately $2 million a year.
And what do we know what the reason was the department turned down the funding?
Just that was a leadership decision, and I think there were some relations to some of the reporting requirements that would be coming for the grant in the coming year.
All right. Mr. Chair, I would ask that we consider at some point if it's not already in a policy, and I suspect it is, that we wouldn't turn down important funding for leadership and important programs without the board being aware of it and frankly being supportive of it. So just as we look to the future, this is very concerning.
I would agree with you, Vice Chair Duncan. That's a important policy decision. And I don't know if there's others on the phone, whether Dr. Stigall or the superintendent, that can address this question of why we turn down federal funding that's critical for the needs of our students without the board's knowledge.
Sure. This is Mark Johnson. Happy to talk to this. Are you referring to the sexual risk avoidance grant, Mr. Duncan?
I'm referring to the Title V funding that we receive.
So you are referring to the sexual risk avoidance grant funding?
If that's part of Title V
That's the
funding, then I
Title V.
think the answer would be yes.
Okay. Well, that money is still going to support North Carolina. Just like other state education agencies, though, DPI is not going to utilize that funding. We got a lot of complaints from teachers, from school board members, from legislators about what that funding was being used for. And again, importantly, that funding is not going to go away. That funding is going to support that same work in North Carolina. It's just not going to come through DPI. It is an HHS grant program, and it is perfectly acceptable for NCDHHS to apply for that. But if North Carolina DPI were to continue with that funding, that would probably mean we would be one of only 2 state education agencies remaining to use that funding through the state education agency, possibly the only one left. And that decision was made after consultation with staff at DPI. The particular person, somebody who was at DPI way before I was, and that was something that was following the lead of other state education agencies. But again, I think the most important point to make is that funding is still available in North Carolina. The same work can be accomplished by NCDHHS or nonprofit groups. However, do not make the incorrect assumption that that was a program that was paying for school counselors or school psychologists. That was the Sexual Risk Avoidance Education Grant Program. And I think the highlight is that money still will support work like that for any district that decides to do it all across North Carolina.
Yeah, to be clear, I did not connect those two. They were separate questions. But let me ask a question, if I could, to better understand this. Has the department received that funding? It sounds like for a period of years up until this year. How many years has the department received the funding until this year? Do you know?
No, I don't know the exact amount. I'm sure Dr. Essick would, and I know it had to be at least a few years. And I believe this decision was made over a year ago, but the money was reapplied for the department anyway.
So the department had accepted it for at least 2 years, if not more? Just trying to get a timeline here.
That sounds correct, yes.
Mr. David Stigall. Ellen, do you know how many years we've been receiving and applying for and receiving Title V grant money at DPI?
Between 10 and 15.
And is
Wait. Was that specifically for the sexual risk avoidance grant education? Just for my own knowledge.
Yes. Yes. The name of the grant has changed over time, and so it used to be called abstinence education, and then it was changed to sexual risk avoidance. It's changed a little bit in terms of how it's administered, but the same. It's still had the same funding source for between 10 and 15 years.
Thank you. I think that's where we started getting a lot of complaints from local districts. Whatever happened to that change, that moved from abstinence to some of the materials that then were being put out is what caused a lot of concern out in districts. And so we listened to districts and to staff. And again, I think the highlight here is if any organization, ours, NCDHHS, wants to use that funding for this purpose, that funding is still set aside for North Carolina.
Mr. Superintendent, is there a reason the board was not consulted about this occurring? I certainly wasn't aware of it, and maybe other board members were, but I was not.
I support what you just said, Mr. Duncan, on really looking at your policies and procedures, because there's a lot of agency decisions that the board is not consulted on. And if the board wants to have more of a view into all the agency decisions, I think that's definitely something that can be created. But many agency decisions are made every day that do not rise to the level of the state board. And I think, obviously, that is something the board can play a role in. So if you want to talk about how we brainstorm and capture all the things that might not normally raise up to the state board and what you want to put in policy, we'd be happy to help with that.
Thank you.
Mr. Vice Chair, I have a question, if I could. David Stigall.
Go ahead.
Yes. I just want to clarify with Ellen. I think, as I remember it, it is for sexual risk avoidance and puberty education. Was there pieces in there for child abuse as well, or is that a separate grant? I know a lot of them run together.
No, so one of the focuses of the grant is positive youth development, and the funder allows us to use the money for professional development for teachers, nurses, counselors. We did quite a bit of training around child abuse prevention, Darkness to Light, which is a child abuse prevention training. We also are using some of those funds right now to help meet some of the sex trafficking training that's required from legislation. The funds that we're spending down as we speak. And we also did puberty education, focusing primarily on 4th and 5th graders with puberty education, so that we were avoiding talking and getting into a lot of controversial topics around sex education, but rather keeping it a very preparing students for their eventual sex education instruction that would happen in their middle schools and high schools.
Any other comments, questions?
Yeah, Mr. Keenan, this is Eric.
Okay.
I think at least one distinction that I see in this matter is this is funding that goes to the districts, or at least affects or supports the districts pretty directly. Is that not correct, Ms. Essex?
Yes, it does. 29 districts receive, I think this past year, approximately $30,000 each. It's been up to $50,000 on some years.
So funding that supports the agency, I see as one thing, but funding that goes to districts, the board has a clear interest in. And I do understand that there's been complaints about this program, and for that reason, even more, the board has an interest in responding to those complaints and still finding ways to support students appropriately in concert with our districts. So that's not in the weeds. That's clear policy responsibility that the board has. And we expect agency leadership to bring these matters to our attention before a decision is made. Thanks.
Thank you, Mr. Chair. Anyone else? Comments, questions? If not, I'd like to thank Dr. Essie and the committee for great work and great information. As we said earlier, it's not the best information, but it tells us that we need to do our very best to reach out for these kids. And when I think about the data that in the information, it clearly tells me that a lot of things happen in children's lives because they're crying out for help. And that's the best way for me to sum this up, is that the information that was given to us by Dr. S clearly shows that these things happen to kids because they're crying for help, want us to get busy and help them. And so again, I appreciate all the comments that was given, very good information, and we will just move forward to try, not try, but to do better as far as helping our kids in this area. And with that, we conclude the issues session. And again, thank you, Dr. S and others.
Thank you.
Mr. Chair, I'd like to move on to discussion with Matt Hoskin. Mr. Matt Hoskin, please.
Thank you, Mr. Keenan, and I hope that this presentation yields some insight in terms of how we can get busy and start helping children. So, good afternoon, Chairman Davis, Superintendent Johnson, State Board, stakeholders. As always, it is a true privilege to have the opportunity to present this information today. As noted, we have an item for discussion in response to a Senate bill, which is Senate Bill 476. And just to remind everybody of that bill and its requirements, the title of the bill does a pretty good job of summarizing it, which is an act to require the State Board of Education to adopt a school mental health policy and to require K-12 school units to adopt and to implement a school-based mental health plan that includes a mental health training program and a suicide risk referral protocol. To also give you all a sense of the timeline that's included within this bill, it states that this policy must be available and made sent to public school units by December 31st, 2020. We really feel encouraged that we get to present at this point in time after we've heard what was really sobering data from Dr. Essick and the Healthy Schools team. They've done some tremendous work obtaining what we know are trustworthy, reliable, and valid data through the YRBS. And what we know is that mental health needs of our students are increasing. We know that this is true for suicidal ideation. We know it's true for the percent of students who feel sad or hopeless, and not only that, have functional impairment as a result of that, which we know are significant signs of depression. And we also know that in the midst of the major stressor of the COVID-19 pandemic, that will likely be a collective adverse childhood event for our students, that our future poses some significant public health challenges if we don't act. And just to put some data behind that statement, and I know there were a lot of questions and thoughts about the current data that we have and how our current state may impact that. I did want to bring up that the Journal of the American Medical Association on September 3rd, so fairly recently, released an article that, and this is among adults, but it found a threefold increase of depression. And not only that, it found higher estimates for those with lower social resources, that had less socioeconomic resources, in addition to those with stressors such as either job loss or a death of a family member. So the preliminary evidence also from a number of studies that look specifically at youth has indicated that same increase, as well as in some situations even larger increases in the threefold increase. So consistent with the conversation that we have had today and with the state board goal of eliminating opportunity gaps, this is a significant aspect of the conversation when we think about mental health. What we know is that the variables that I just described that were associated with the poor mental health outcomes is that those unfortunately impact students across the state disproportionately among socioeconomic status and race. In addition to that, there, as we know, is disparate access to mental health supports relative to those same aspects. So we find ourselves in a situation where if we do not act swiftly, we will have circumstances that have a high probability of exacerbating opportunity gaps. We know that there are strong associations, the research is very clear, between poor mental health and poor academic and post-school outcomes. It includes graduation, dropout, substance abuse, employment, incarceration. Unfortunately, the list goes on. And so what we just received from our Healthy School friends is data, and data that serve as a flashlight into the future. And it provides us with a professional and what I believe is a moral obligation to respond. As we heard previously today, as Ms. McCall stated when she was questioned by Mr. Bristow Smith after his presentation, we really do need to be acutely aware of how history will judge us in this unique time in history that really does present an opportunity for making meaningful and lasting change that will benefit students of North Carolina. Our future citizens will know what we know. They will know what we were capable of, and they will have the benefit of knowing how we responded and what that outcome was. And I do also want to mention that Dr. Oxendine and Dr. Emery really insightfully shared a quote today that I think rings true with what we've heard today. And this is a quote from Ron Edmonds that says, "We can, whenever and wherever we choose, successfully teach all children whose schooling is of interest to us. We already know more than we need to do that. Whether or not we do it, it must finally depend on how we feel about the fact that we haven't so far." So we are at a critical point to make some decisions about what our priorities are. And even if we don't feel compelled by the obligations that I've just talked through, we can also appeal to just our fiscal responsibilities. In 2016, the Lancet, which is one of the most respected scientific journals, published an article that discussed the return on investment of $4 for every $1 that's invested in prevention and treatment of anxiety and depression. So we know what is ahead of us, and we know what the right investments are. We have data-informed, wise investment strategies for students and families, and largely the future of our state. Deanna, if you don't mind to go to the next slide. So we know that we have formidable challenges that we're facing, and we have the responsibility to overcome those, but also we have a real opportunity right now to respond and measure. And when I say respond and measure, we have what we can lean upon is the really incredible and tireless work of educators, of school and community mental health providers, of parents, advocates, and stakeholders across the state who have figured out how to do this work well. We have right now the collective foresight, and we can advocate, implement equitable access to evidence-based practices that we know work. And we have some data to demonstrate that we can do that both effective and efficiently. And what we know when we think about equity is that for mental health supports, schools are the absolute prime location for the provision of those services. Quite simply, it's where kids are. Students are required to be there at least 6 hours a day during the year in typical circumstances. And importantly, and in some of the data that we found in some of our surveys across the state, we also have an obligation to ensure transportation. When we did a survey in 2016, we reached out to a large number of parents, and 1 in 4 parents said that a lack of access to transportation prevented them from getting their child access to mental health services. What we know is that when there is a school-based health center, students are 21 times more likely to access health services. When we think about equity, when we think about the circumstances facing us and knowing that kids get the supports that they need, it really makes sense that the school is a hub for mental health services. There really is no other school setting that can provide that same level of services, particularly as we think about prevention and universal access to mental health and social emotional learning supports. So I really think that the greatest work that we have ahead of us right now is to be that lever of resiliency that allows students to overcome the adverse situations that they're finding themselves in right now. And as in the slide that was just there around the policy to practice feedback, the policy that we're going to share with you in just a moment is not just the result of speculation and conjecture of our DPI staff. It is the result of multiple years of input from a very diverse set of stakeholders that we have had really the great honor to bring together through the North Carolina School Mental Health Initiative. And not only that, the policy has also been informed by our Project Aware sites, who are right now actively doing the work and whom, with their grant obligations, are charged with informing the state about sustainable and scalable practices that are not only effective, but also ones that can be feasibly implemented within the context of schools. So this is a policy that is truly informed by practice. While it is aspirational and it's ambitious in nature, we also know that when sufficient resources are put in place, that it's pragmatic and it's absolutely achievable. So this policy that we're going to present is informed by practice, and we know that it can be done when the resources are there. And with that, I think that I've discussed most of this, Deanna, so I'd like to hand it over to my colleague, Dr. Lauren Holohan, to discuss some of the specific features of the policy that we've shared with you.
Thank you, Dr. Hoskins, and good afternoon, board members and others on the call. I will be brief. I know you have the draft policy as well as a couple of other supporting documents. I'll make some connections for those. So Deanna, we can go to the next slide. And just so you know, to reiterate and add to what Dr. Hoskins just said in terms of what were the sources that we used to develop this draft policy, certainly the legislation itself, Senate Bill 476. We drew heavily on your previous policy, SHLT-003. And as Matt said, many years of stakeholder input. And I would say, also importantly, the stakeholder input that we got from local district leaders since the pandemic began, as we built our COVID response resources specific to crisis intervention and social emotional learning. We got just incredible amount of very valuable and specific information about that we were able to also use for this policy. Finally, last fall, 2019, we conducted a resource mapping of all of the existing school mental health work that was being done across both DPI and DHHS, and you have a copy of that report. And I would draw your attention to Table 6 as the recommendations. We also considered those as we put this policy together. So there really are two main features of the policy that you have to consider. One is that the legislation requires the development of a local school mental health plan. And those plan components, as we've laid them out in the policy, would have a universal or core prevention feature in which we do things like Dr. Essick mentioned earlier of integrating social emotional learning competencies across the different content areas. And it would also include the mental health training program that I'll discuss in just a moment, as well as equipping school personnel in the use of the implementation of a suicide risk referral protocol. And that would be required training for school staff, school personnel in grades 6 through 12, and certainly recommended for K-5. And it would, at the very minimum, provide guidelines on how to identify students at risk of suicide, and also then how do we respond when those students are identified. That would all be part of our universal prevention. Early intervention really focuses on supports for students we've identified who are at risk, and include all of our efforts to promote mental wellness and social emotional health. And again, we would see this as being implemented through an MTSS framework, and also through other structures like school health advisory councils and other existing teams. And finally, that more intensive level of support in these local plans would outline how the school is going to interface with community providers through referrals, how the decisions about where treatment will occur, and then reentry back into the school if the student has had a community placement. So we can go on to the next slide. And just some additional features of the plan. We also included, as we did in the previous school mental health policy, a requirement for a memorandum of understanding between the LEA, the PSU, and the local management entity, or the managed care organization, the LME, MCO, and or other local mental health providers and substance use counselors, so that we do actually have that full continuum that extends beyond the school walls when the needs of students are such that they can't be met by school resources. There's also a hold harmless statement that schools would not be held liable for civil damages in relation to the policy. And then I mentioned the suicide risk referral protocol and the features of that. The reporting requirements are that by September 15th each year, the PSUs will report to DPI, and DPI will need to develop some kind of reporting mechanism, platform, letting us know what their plan is, how they've implemented it, and how they've complied in the year prior. And then the timelines are that this initial plan by the PSUs will be ready to go by July 1st of 2021. And by ready to go, we mean they will have a plan, they'll be implementing that plan, and they will commence with their training. And I'm going to talk about that training, those training requirements in just a minute. They will begin training of their staff. The mental health training program is provided at no cost to employees. The initial training would be 6 hours, and then a refresher each year of at least 2 hours. And the contents of that would include, according to the legislation, youth mental health, suicide prevention, substance use prevention, teenage dating violence, and that is also in accordance with Session Law 2019-245, child sexual abuse prevention, and sex trafficking prevention. We can move on to the next slide, Deanna. Target audience are teachers, instructional support personnel, principals, and assistant principals. And we have also recommended an additional package of training for those specialized instructional support personnel, particularly the 4 groups of practitioners that Dr. Estig mentioned: school social workers, school psychologists, school counselors, and school nurses. We kind of outline how that might be delivered through virtual, online, or in person, and also who are the recognized organizations or entities that could provide that training. We also are encouraging preferencing of material that is low or no cost, and we know there's many quality options out there that meet that standard, as well as alignment with the National Center for School Mental Health curriculum. The annual reporting requirement for DPI is we collect that information by September 15th from the PSUs and then turn it around by December 15th in a report to the legislature. And then we would have a requirement to, beginning August 1st of 2025, review on a 5-year cycle the policy and all of its parts to ensure that it's up to date with the evidence. And I think I'll send it back to Dr. Hoskins.
Any comments, Dr. Matt Hoskins?
I apologize. Are you able to hear me now, Deanna?
Yes, sir.
So we did complete an initial analysis of potential costs associated with supporting the implementation of this policy, and I know that we've, over the course of today, even had some discussions about that. This preliminary analysis, where that came from, is the data that we have from our Project Aware grant that we're currently implementing, where we're seeing things being implemented well, and that initial cost of with the funds that they are receiving through state aid is $46 per student. What we also know is that through the really intentional work of MTSS and social emotional learning, that some of the infrastructure work that not only involves work that's being done in the districts, but also work that we're doing within the state agency to ensure that we have staff that are able to support that we have a strong state level team that can support school level teams. We know that some of that initial cost that we, based on our budget for that project, we think we already have the capacity for, and at a per pupil level, we found that to be about $12, which would be a cost of $34 per student. The breakdown that you see here is, again, specific to our funding formula for the Aware grant in terms of where funds would go from direct services to students. You can see that's at 25%. Mental health promotion and professional development, both of which act as a really preventative nature. We know from this work that implementation looks very different from district or PSU to PSU. And as a result of that, we have to collect data to be able to make informed decisions for moving that forward. And then to the questions that were already posed as well, we know that there's just going to be some personnel costs associated with increasing personnel where we have ratios that aren't quite where they need to be yet. And so this is the total cost. We do anticipate that what we know when preventative work happens, that the cost as it moves forward reduces over time, and we would expect that to happen after.
Dr. Hoskins.
Dr. Townsend Smith, I think that was his last slide, and I think we could move to questions, okay. and we'll hope that he comes back to us.
Okay, thank you. Mr. Keenan.
Yes, thank you. Any questions or comments from the board?
I do have a couple, Mr. Keenan.
Please do.
A simple question, I think, just because I'm not sure I understand the terminology, but there's a requirement for every PSU to have an MOU regarding access to local management entity and managed care or / managed care organization. Does every PSU have access to one of those things?
Yes. The LME-MCO map, it doesn't align with our education districts in any way. So we have some LEAs that are actually served by multiple LME-MCOs. We can easily provide you with that map. There are seven or nine LME-MCOs.
Oh, okay.
Yep. So yes is the answer.
Right. And then a thought that occurred to me previously in Dr. Essig's presentation, and then also in this one, when we talk about the need for more personnel and more of our team of professionals, it occurs to me that other than funding, there's an additional problem in that some districts are going to have a hard time just finding those people. And that seems to be a big part of this problem too, that we haven't really touched on. But aren't there shortages of trained school psychologists in pretty broad areas of the state?
That is true. And we aren't currently, I know in conversations with Len McClure, we aren't currently producing enough school psychologists in our programs inside of North Carolina to meet the need.
And that would probably be true for nurses and social workers as well?
That I don't know. I do know that is the truth for also for occupational therapists who would be included in that group of folks who would be addressing these types of needs for students.
So were we to get the funding, that would also be a problem we would have to deal with. And final question, was there any funding attached to this legislation?
There was not.
And just to go back and address the prior question as well, is that we have some compelling reasons in North Carolina for school psychologists to be interested in practicing here. So we have specifically targeted states that have training programs that produce graduates that exceed the number of openings that they have, and recruit them to come to North Carolina for the compelling reasons around policies that we have that provide them some expanded roles. So I think that's a critical area that we're focused upon. And in addition to that, we also know that we have folks who are licensed within the state that are not currently practicing. And we are collecting data right now to see why they're not currently practicing, whether they would be interested in returning if there are opportunities to do so. So it is true that we will need to continue to fulfill that need, but we also have some ways, I think, to fulfill some of that need. And in addition to that, as we think about prevention and to address one of the questions that Mr. Kien asked earlier, specifically when we think about the implementation of universal social emotional learning supports, that's really at the preventative nature. We can build capacity among all staff to do that and integrate that within the curriculum. And we don't necessarily need specialized instructional support to begin that universal and preventative work.
And just to follow up on Dr. Hoskins and what you just said, being the from the Northeast region and representing that part of the state, the additional problem is that it's difficult. There's so many shortages there, even amongst in teaching positions, and it tends to be hard to attract those professionals to some parts of our state, and that's another problem we're going to have to address, I think.
I agree with that, and I think we have some initial ideas that we are exploring, considering regionalization and how we can bring multiple districts together that may not need to hire a full-time staff to entice those specialized instructional support personnel to go to those hard-to-staff districts.
Brilliant. That sounds like a good idea. Thank you.
Any other questions or comments? Thank you, Dr. Hoskins, on that great presentation. Thank you very much. Mr. Chair, I would like to make one comment as I sum it up, if I may.
Please.
When I listen to the information given to the board by Dr. Estes and others and Dr. Hoskin, I just think about the what I call the, as I said earlier, children that are crying out for us. And, you know, I'm proud to be a part of a board based on a lot of conversations in the past and based on the conversation question asked today, that we have a board that really truly care for those who are downtrodden and those who need help. And we can't make this walk alone. We need other stakeholders. That's well known. Dr. Hoskins said, great idea, we can find the resources. But I think we have a board, and I think we have people on board that will not stop. We will continue to knock on the door, knock. Don't give up. Sometimes we live in a bubble. Not only us, whatever, but sometimes people live in a bubble. When you live in a bubble, you can't touch certain people. You can't talk to certain people. And I think things get better when we get outside the bubble. And God has given me a lot of gifts. And one of the best gifts God has given me is He allowed me to live in a community that where I do not live in a bubble, where I can touch the kid who needs help, where I can hug the kid that needs help, where I can kiss the kid that needs help. And I just say that to say that I'm asking others outside of the board to help us. More importantly, help our children. They got to believe in themselves, but they can't do that unless we help them believe in themselves. And with that, I'm just going to conclude, but I just want to tell you how I was feeling about today's session. It was great information, and I'm ready to go fight the battle any way I can. Thank you, Mr. Chair.
Thank you, Mr. Keenan. Chair Davis has stepped out for a moment, so I'm his temporary poor substitute. I want to thank you, Mr. Keenan, for these important reports today from the Healthy Responsible Students Committee and for your work on the committee and your comments at the end of our committee report. I also want to thank Dr. Ford and Ms. Kamnitz for their leadership in the strategic planning committee and the quality of the planning and work session program that was presented today. I think at the end of every day this week, Chair Davis would like us to have a moment for any reflections that any board members have haven't had a chance to think about the presentations being made as part of the planning and work session. And so I want to turn it back to Dr. Ford and Ms. Kamnitz in order to receive any reflections any board members would like to share at this point based on today's planning work and session.
Thank you for that, Vice Chair. I'd like to begin by saying I'm going to receive that everyone is speaking prophetically when they call me Dr. Ford. I have not yet attained that status, but it's something I'm actively working on and probably have a couple years left in my program. Nevertheless, I just want to thank all of our presenters, our panelists for today, the engagement from all of the board members. We've continued to impress upon everyone the pregnant nature of this moment, that we do stand on the precipice of something that is unique, and recognizing and inviting in the unique context and position that we find ourselves. It can create some anxieties. It can create even some fear and some trepidation. But speaking again with the historical lens, the one thing that is constant in life is change. And what we do with that, what we do with the time that's afforded us, is up to us. Dr. King is quoted as saying, as a critique to folks who have said, just wait. He said that time is neutral in the end. It's about what we do with it. And the time is always right to do what is right. And with that in mind, I just want to continue to encourage us as we go through the rest of our presentations this week, to bear that in mind, hold that front of mind and top of mind, and to have it at the ready as we encounter these presentations. I also want to appreciate and acknowledge an area where we perhaps could do better, and that is the greater centering and inclusion of indigenous voices in these conversations. And I want to publicly, if it's all right, appreciate my colleague, Dr. Oxendine, for pushing me on that point, that as we talk about equity, there's a need to make sure that the voices of American Indian indigenous students are included, as well as educators in the conversations as well. So with that, I will yield to my partner, Ms. Kamnitz.
James, I couldn't possibly add to what you just said, so thank you.
Thank you, and thank you for your leadership. Any other board members like to comment in any way at this point?
Chair, Vice Chair Duncan, this is Olivia.
Yes, please.
Just a couple of 1 minute or so of a comment around social emotional. Much of our discussion today has centered either directly or indirectly on the topic. And I would be remiss if I did not say that we have to see the social and emotional, understand it, comprehend it as not single, isolated pathways that are dependent or independent, rather, I'm sorry, but they are interdependent. There are other pathways. The one that immediately comes to mind is, of course, the physical, but also the intellectual pathway. We talk about intellectual pathway, the term academic performance comes to mind first. So it really takes all of those connections in order to build what we talk so much about, the whole child, educating the whole child. It takes the social, emotional, so important, because that causes the child, the student, to feel good about himself or herself. And we know that when we feel good about ourselves, other good things are likely to occur. And it shows up in grades, it shows up in self-efficacy, it shows up in trying hard, it shows up sometimes in discovering talents that the child or student was totally unaware of. So I suppose what I'm saying is Olivia, I'm going to speak for Olivia, needs to constantly remind herself that we're not just talking, social emotional is within the whole context of the child, and they all have to be clicking to the highest degree level possible. Thank you.
Thank you for sharing those very fine thoughts, Dr. Oxendine. Any other members who have any thoughts to share? Ms. White?
Thank you, Mr. Vice Chair. I have been thinking hard about the panel discussion this morning, and it was excellent. I want you to hear me when I say that, but one of the discussions gave me pause, and that was the part of the panel's discussion that emphasized hiring educators that look like students in the classroom. And by and large, I very much identify with that. It is important for our students to have someone in their school setting that looks like them. But the conversation became much more important and much more relevant when we shifted to the conversation about relativity and teachers having the knowledge, the skill set, and the base to connect with students that far transcends connecting with students just based on the color of our faces, because students come in all shapes, sizes, and colors. When I think back to my own educational experience in Garner, North Carolina, my favorite teachers didn't look like me. In fact, one was, I'm 5'9", you can't see that now that we're virtual, but one of my favorite teachers was 5'1", white, bald, gay male, none of which I am. My second favorite teacher was tall, balding, middle-aged, but he had a passion for music that I absolutely adored and respected. And I dare say that if we asked any person who has completed any of their educational experiences, that when we ask them to think about the educators who made the most significant impact on their lives, it won't be about the delivery, the instructional delivery. It will be much more about how that teacher connected with them and how they made them feel. So I want to remind us of that and focus our training more so on equipping our field of experts, our educators, on developing those skill sets that will best equip them to meet the needs of the SEL, the social emotional learning, because I do believe that is the most important tenet. It is the foundation for which all students succeed.
Thank you. Very helpful thoughts. Any other thoughts that any members would like to share? All right, thank you to everyone for your participation today. It's been a really great start to our meeting this month. This concludes our planning and work session for today. We will convene, as a reminder, at 10 o'clock tomorrow morning. Tomorrow and Thursday, we will conduct planning and work sessions in the morning and our regular scheduled meetings in the afternoon, immediately following the planning and work sessions. So for today, we are adjourned. Thank you.